I will focus on knee osteoarthritis patients. As I said, it's work done by my colleague Josien van der Noord and also the PhD student Rose Richards. And in fact, it's part of a whole team that we're looking at how to improve the life of patients with knee osteoarthritis. Where I'm from Amsterdam, from the VU University, which is in the south of Amsterdam. We are part of a research institute called MOVE. That's where we do our research efforts. And the laboratories we entertain is within the Department of Rehabilitation Medicine. So it's really very clinically focused. And so the main aim, so to say, of our laboratories is to make people walk better. That's simply put. We try to do it in two ways. One is providing clinical services to the clinicians in order to inform them about the clinical decision making they have to do. This is what the diagram shows. But obviously also research how to improve and how to find out what works and what doesn't work. These are a few pictures of our laboratories. On the left-hand side is the overground lab with a motion capture system and embedded force plates. And on the right-hand side you see the rail system. It's an instrumented treadmill with virtual reality environment, and that's the part we're going to focus on today. Sorry. All right. Talking about knee osteoarthritis, as I said, it should be driven by clinical questions. So what's the actual problem? Well, patients complain of pain and swelling, limited amount of walking distance, and this might all go back to the damage of the cartilage. This is a typical X-ray, and you can see easily here. This works into that. So on the medial side, the narrowing of the gap between the femur, so really demonstrating that the cartilage in between has been has gone away. So it has worn out. So how does this relate to biomechanics? Well, the idea is that one of the factors that contributes is the increased load on the medial condyle, leading to instability. Muscle weakness is also part of that. And it has been shown that gait mechanics do influence the morphology, mostly meaning the thickness of the cartilage and osteoarthritis of the knee. This is a model that is suggested by Andriachi. There are several models around, but it's all based, and in normal circumstances there is a good homeostasis of the cartilage because of between the load and the actual biology that keeps it in shape, and so it's all fine. But sometimes due to increased weight or increased aging or trauma, there might be changes, and then the load is no longer in balance with the actual loadability of the cartilage, and then there is a process of degeneration. And the idea is to reverse that by means of adapting the loads, because in the very end it will damage the cartilage to that amount that the only possible therapy then left to relieve patients from pain and increase their mobility is a total knee prosthesis. But that's something we would like to avoid as long as possible. All right. There are some mechanical factors like malalignment, trauma, increased weight, of course, and instability of the knee itself is also contributing to increased load. And the conservative treatment therefore aims to minimize it. Well, to decrease the load, there are several ways, conservative ways of therapy that can be done. Of course, one of the most effective is weight management, but that's not always possible. So there are orthotics like wedges or knee orthotics, but also gait retraining and balance exercises, all to improve the load to minimize the actual load on the knee in order to avoid the eventual total knee arthroplasty. Okay. However, it's not always successful. Well, let's focus on the actual increased load on the medial condyle here. We can then, if we walk that a little bit out in detail in order to know what we're talking about, we should realize that a shift from the external load external force to the medial side is indeed increasing the stress on the condyles. To calculate this very precisely, it needs very, very advanced biomedical models. You can see an example here from Melbourne, where after all kinds of imaging and segmenting and also putting in the muscle forces from Gait analysis, you can come to a pretty precise, I'm not saying accurate, but at least precise, because it's a real challenge to get it very accurate idea of what the actual load is. But this is not very practical in most cases, so can we get into a more simple model? Well, to realize what the load in the medial condyle is, I'll take you to some biomechanics, and if this is the actual situation, in blue is the ground reaction force, medial from the knee. This is in most cases, this is the case in most of the during most of the Gait cycle. We want to know what the actual load on the medial condyle is. We should realize that the balance of moments around this point is maintained by the force of the biceps, femoris, and the other muscles, but just consider this one. And then we can see that if we look at the relation between this medial compression force and the actual lever arm here, so it's about how far away the ground reaction is from that contact point, there is a linear relation between the two. Usually in Gait analysis, this point is not taken as a point of rotation, but I should use this one. It's the knee adduction moment, which is calculated using the center of the knee. Well, this is not, this might not always be perfect center, but actually it's a measure that is also linearly related to this medial force. So you can use, assuming this simple case of biomechanical reasoning, the knee adduction moment as a proxy, so to say, for medial load. The question is this theory, and is it actually true? Well, of course this is hard to determine, but from the instrumented knee prosthesis we know that there is quite a nice relation between the knee adduction moment and the medial condyle contact load. At the same time, well, Professor Bergman, his keynote speaker at this Congress, will elaborate on this a little bit more. But you can also see that although there is a nice relation, there is still lots of variation. So at the same knee adduction moment, the predicted and the actual medial condyle load can be half as well as double. So there's still a lot of spread around. And part of that is because it's not just the frontal plane, of course, it's also the sagittal plane. So it is in fact much more complicated. But nevertheless, we could use the knee adduction moment or as a proxy for knee load, and it has been shown that this is can be done, and also that an increased knee adduction moment is related to the severity of knee osteoarthritis. So you can see actual alignment that increases the lever arm, and therefore you can see the red one is the severe, so it's the knee adduction moment is increased for these patients. So as a proxy, we want to use the knee adduction moment. So then it's pretty easy to measure. You don't need lots of biomechanical modeling to do so. So we can apply straightforward laboratory measurements of the ground reaction force and use a simple biomechanical model to calculate the knee adduction moment. And when visualizing it, you can see here, actually it's a video recording with projected ground reaction force. You can see that the distance here is a direct measure of the knee adduction moment. So this is pretty straightforward. All right. So one of the aims to minimize knee load is to minimize the knee adduction moment. And you can do that by either minimizing the ground traction force, of course, but in cases that it's not possible or that the achievement of that is not enough, you can change the alignment and minimizing the distance of the line of action of the force towards the center of the knee joint. So we can try to do so by applying gait modifications. There are many authors in the past has indeed tried to explore what is the effect of all kinds of modifications of gait in order to minimize the knee adduction moment. Many authors contributed. The results weren't always in line with each other, but it's a general idea. This is the normal gait. You can use either toeing out in order to have the point of application of the ground friction force more to the lateral side, thereby shifting the ground friction force more lateral and minimizing the knee adduction moment, or shifting the center of mass, especially of the trunk, and thereby redirecting the ground friction force by trunk leaning. So these are the two main mechanisms. What we did is we tried to compare all those effects into one, because they're investigated using all kinds of different studies, but now we try to do it into one study, and we compared all those gait modifications, also toeing in, by the way, because toeing in, which is driven from hip rotation, brings the knee more internally when the knee is flexed. So this might also be a contribution. And we compared all those, not yet in knee osteoarthritis patients, but in healthy subjects. And you can clearly see that there is an effect, and the effect of both the trunk sway as well as the toe in minimizes the initial load peak on the knee adduction moment, and thereby the load on the knee. Toeing out, and it does not affect the knee adduction moment in the second half of the stance phase. The toeing out is slightly different because it increases the initial load, but it decreases the final load on the knee adduction moment. So, we can explain that by going more into the details, and the knee flexion contribution is also part of that. So now we know it works. We can influence the knee adduction moment by gait modifications, but can we also do this, use this for gait retraining? When we look back in the literature, and we look at all the literature, gait retraining using feedback, real-time feedback, has been performed a lot, but not so very much in musculoskeletal disorders. And also long-term follow-up studies haven't been applied. More recently, there has been an interest in using feedback for knee osteoarthritis retraining, and some focusing on kinematic feedback or haptic feedback or even audio. You can see a nice sensor setup that, of course, it can also be worn outside the laboratory. But first of all, we need to explore inside the laboratory what makes sense and what does not make sense. What kind of parameters should we feedback in order to really effectively reduce the knee adduction moment? Should it be kinematic, kinetic, or maybe spatial temporal? What way should we do it? And what kinematic strategy should we use to decrease the knee adduction moment? Here you see some results. This is from Barrios, who try to minimize by feeding back the actual adduction angle of the knee. And you can see we used eight sessions. You can see that indeed the initial peak was minimized, and by indeed a decrease of the knee adduction angle, which was driven from the hip angle. Right. Both the rotation, was more internally rotated, as well as the adduction was slightly down in order to achieve this. This was the feedback, and this was effective. Wheeler used a direct feedback of the knee adduction moment, showing a screen here in front of this is an instrumented treadmill. Of course, it's an instrumented treadmill, otherwise you can't measure the knee adduction moment. So there was a real-time biomechanical model that calculated it, and the person was asked to minimize for each step the adduction moment in a strategy that could be chosen. You can see here some of the, it was done by vision and also by vibration as feedback. And the nice thing is they also added what is called a awkwardness rating, and well, it doesn't feel good for people. So that's the downside of it. It does minimize the knee adduction moment effectively, but still people feel uncomfortable, and well, this is probably not going to help to sustain. Also, Hunt showed that by using trunk sway and using a big screen in front of the person, it is indeed effective in minimizing the adduction moment. Also, the showing out is effective, also feeding back the screen. What our research is about is that we use the rail system from Motic Force Link, which comprises not only an instrumental treadmill and a motion capture system, but also a screen, semi-cylindrical. So it's almost all of the side of the person is feedback by this virtual reality environment that goes in sync with the belt speed. And the actual software using the HCBM model from Tom van den Boogaard is able to real-time calculate the knee adduction moment and feed it back. So this looks a bit odd, but it should normalize after I started it. Here you can see someone walking, and in front now is a graph projected with the knee adduction moment. This is a kind of not very realistic, but still a nice virtual reality environment. This video runs slow, I don't know why, it should run in real time. And in a moment you can see that the person is applying the towing out strategy and in order to explore whether he can minimize the knee adduction moment in that way. I don't know why it stops so soon. Well, I think this is just informative. What we try to do is to feedback the knee adduction moment directly, but also we try to explore what is the effect of a direct kinematic parameter, so something that people could directly influence by adapting their walking pattern that we know was effective, which is the hip and the rotation. We used 4 visual types of feedback: a bar, a polar plot, some changes of color from red to green, so it's intense color intensity change, as well as the graph, as you just saw in the video. For the knee adduction moment, we did give no further instruction on what to do. We just said, well, try to minimize it. This was done in healthy young subjects. When feeding back the knee adduction moment, you can see that it was pretty effective. Sorry, the agenda shifted here, but all you need to know is that this is a normal one, and all the 4 types of feedback give more or less comparable results. There was no specific type of feedback that did matter. But, as you can see, the actual minimizing of the knee adduction moment was around 50%, which is a lot. For the hip angle, it was the same. This is normal, and all the 4 types of feedback did result in the same change of hip internal rotation. So both the kinetic feedback as well as the kinematic feedback did work well. However, we saw that the feedback parameter did matter, because although the patients or the subjects were pretty effective in minimizing the hip rotation angle, it did not result in a minimizing the knee adduction moment. So although we have established a relation between the kinematic parameters in general, trying to influence it, and the specific outcome parameter we were interested in, the knee adduction moment, it did not result in a minimizing. So apparently people, when minimizing the knee adduction moment, use a very specific personalized kinematic change. And by analyzing all the kinematic changes that people applied by minimizing the knee adduction moment when they had the feedback on their knee adduction moment, we saw a variety of strategies on how people did it. So it's not straightforward how people comply to that command. So in order for these strategies to be sustained, individual selection is important, and this was also established by Tim Gerbrands earlier on. The towing in and out must not be very much off, because the more it's off, the more it feels awkward. Lateral trunk sway generally is something that is effective in minimizing the knee adduction moment, but it's very uncomfortable and it increases energy costs, so that is unlikely to sustain. Also, the instructions to the patients matter during walking on the belt. Do you keep an internal focus or an external focus? Do you use implicit learning, what we call implicit learning, by feeding them back the final parameter, or do they want explicit instructions like, could you try walking with your toe more inward, or with your trunk lean a little bit more to the side? So that all matters, and it's also dependent on the skills of the actual physical therapist who is operating along with whether this can be achieved. But most important, what kind of motor learning strategies are in fact effective, because it has to do with change. So when you look at the retention of the learned motor pattern, you see that people, they memorize it and they are able to do this on the short term, but the longer term is, well, not very well investigated, and some reports report that it's reverting back to the baseline, but some studies also report improved or even extended performance of the actual training session. So if you look at the characteristics of those, one of the key features is that the feedback parameters need to be a kind of faded instruction. Here you can see that the faded feedback approach means that although the time of the training sessions can increase, the time that's actually spent using feedback is becoming less and less. And it is just to learn how to do it actually without the feedback. So initially you use the sessions to learn people how to do that, the walking pattern, and then you want to learn them how to sustain that without the actual feedback. So it needs to fade out. All right. And here is some of the results that actually show that in the long term, with this 1 month follow-up, there is still a retention of the results. Finally, we are going to follow up on these studies by trying to investigate what eventually the 6-month follow-up will be on a 6-week training session, employing this faded feedback protocol, and try to also investigate what either implicit learning by feeding back direct in the knee adduction moment, or changing all kinds of kinematic parameters very specifically instructed by the physical therapist. This is part of the NEMO. Of the NEMO, which is a European network, initial training network of researchers that are trying to explore what biomechanics are exactly important to slow down the knee osteoarthritis progression and what are the most effective therapies for these patients. So in conclusion, there is an immediate effect of real-time visual feedback. The long-term effects are promising if you apply the right protocols, but lots of things that need to still need to be explored in order to find out what the optimal motor learning strategies in these patients are. So this concludes the knee osteoarthritis. So, do you have any questions at this point in time? No? That's all clear? Then I'm going to progress with Andrew. Who's going to talk about scope.